Well, hi there, everybody. Thank you very much for joining us this afternoon for another LBG medical webinar. My name's Simon Barthold, and I'm going to talk to you today about something that's very dear to my heart, and I hope you enjoy. Webinars, but basically what I want to talk to you about today is gender issues in sport and what's it all about. So specifically I want to talk about the issues of women in sport and explore exactly how female athletes are different to male athletes and what it means to us as treating practitioners. Okay, so the issues, I guess most of the ladies that have seen this slide before can identify with this. It's kind of interesting that we put up signs when we're at work, but women don't tend to do that, but that's another whole story, I guess. I guess that one of the most important things about gender, and I'm going to be talking about this, I suppose, in a running context, is that when we look at the participation of females in sport, and particularly in running, it's a very dominant market force. So in fact, for quite some time now, we know that there are actually more women runners than men. This is from Jack Taunton's incredible longitudinal study of over 2,000 athletes. So since at least 2002, the gender skew, the gender bias, has been in the direction of women. So we know that there are more than 50% of women make up the entire running population. Now the interesting thing about that is, if we look at the most important piece of equipment for a runner, that being the running shoe, there's still a real tendency to what we call pink it and shrink it. In other words, just take a men's shoe, make it look pretty, and downsize it. And I'd have to say that for us now in 2015, and for somebody like me who's worked for a long time in the field, that's nowhere near good enough. So I think, you know, despite the fact that we've got this fairly large market influence, the manufacturers are largely making running footwear for male runners and then just basically downsizing it. And this is really, I think, a pity and not good enough, because women do have very significant injury issues compared to men. And I might just run through a few of those injury issues with you right now. So if we have a look at the injury rates between the sexes, so we're talking about the actual demographic here, it's important to note that that there's actually no difference in the amount of injury. So women and men have about the same incidence of injury, but there's a very large difference in the injury type. Andrew Shackey outlined this way back in 2002, so we've got a pretty good handle on this. One of the reasons we think this might be is that there is not only a fundamental difference in the biomechanics of female athletes versus male athletes, but there's also a very large difference in the actual morphology of female feet compared to men's feet. They are actually different. So we need to make a recognition of that. And you can imagine that this is really very important when it comes to things like footwear design. If you're just basically downsizing a men's shoe, you're going to have all sorts of fit issues, and I'll go through that with you a little bit as we explore this webinar. So if we have a look at some of the actual injury issues here, you can see that in terms of things like patellofemoral syndrome or patellofemoral dysfunction, whatever you want to call it, depending on which particular research paper you read, women runners are about twice as likely to get anterior knee pain compared to men. So it's far more common in women, and it's very, very common in young women. So a very large bias there in the direction of females. If we have a look at things like ITB pain, again, about twice as likely to develop iliotibial band friction syndrome compared to men. We're talking about the running population here. So again, quite a big skew in that direction. Talking about gluteal injuries, a pain in the butt, as we like to say, women are at least 3 times as likely to develop gluteus medius injury compared to men in running. And if we have a look at the next major injury profile here, sacroiliac joint, so low back pain during running, about 10 times as likely to develop this particular problem compared to men. So these are fairly interesting running demographic figures, and they certainly do tell us that there are really major differences between the genders in terms of the injury. Okay, so we can identify those things, and we're going to talk a little bit later on about also some of the really big bogeys like ACL injury. But we know that there are these differences in terms of the injury type, and I just want to reinforce again that there is no real difference in the injury rate, but there is a difference in the injury type. So why might that happen? What are the reasons why that might be the case? Well, we certainly know that there are some fairly major structural differences between female athletes and male athletes in running, and the suggestion is that these differences in structure are probably playing a role in predisposing female athletes to these particular injuries. Women run differently to men. That's a simple fact of life, that female runners are quite different, and for those students of GATE out there, you'd all be very aware of this and would have many times observed the differences between men and women, but we're going to run through these one by one. So certainly there are skeletal differences, there are structural differences, and these do make women run quite differently to men. So obviously if you're running differently, we all understand the issue of how tissues are stressed. If you're running differently, then you change the loading patterns. Running is a very repetitive sport. We view it as a linear sport. So when you're changing the loading patterns over a lot of repetitions, you can have an issue with injury. So that's basically the way it all slots together. So some of the structural differences that we see in female athletes, and one of the key issues here, just excuse me 1 second, I just want to find my little doodad here. There we go. It just goes off the screen every now and then. Sorry about that. So one of the things that we do know about structural differences, I think what a lot of people believe and quite often state is that women have a wider pelvis compared to men. Now, this is actually probably not the case, and it might seem like we're splitting hairs here, but the fact is that the absolute and also relative pelvic width between men and women is actually quite similar. But what we actually do see is that there's a greater hip width to femoral length ratio. So there's a change in that ratio. So there's no absolute or relative increase in hip width, but the ratio is different. And what happens then is it changes the mechanics in a manner that leads to greater hip adduction, adduction. Now this is one of the single most important biomechanical differences between men and women. It creates a lot of changes in a lot of different structures, and we can probably fairly accurately relate that back to the injuries we see in female runners. The other major issue we see in female athletes is that they have a greater standing pelvic tilt angle than males. So in other words, they have a greater anterior pelvic tilt, and as you'll see in a little bit, this also can be very relevant to injury, and we'll talk about that in a minute. So the result of all this is that women have a greater static genu valgum than men, and it's very easy to observe this in most female athletes, and also it leads to strength. It can lead to strength deficits higher up the kinetic chain. So we quite often see, when we're doing our dynamic testing, we quite often will see women struggling to do either a squat or a single leg squat, very prone to weakness around the hip flexors, gluteus medius in particular, and they have this very real static genu valgum that does create some issues. So I can illustrate this to you with a short video here in a moment, but if you look at even very good, sometimes even highly trained or elite athletes, you can often see that their genu valgum is a lot higher than men. We're going to take a look at Pyrenees here. So this is a very good junior sprinter, and I want you to have a look and see what happens when she simulates coming out of the box here. In particular, have a look at her left knee. Oops. And you'll see what happens here. So out she comes, and you can see immediately on both sides that she's got this very large, this is dynamic genu valgum. Now I'm going to play it one more time for you. So you can see out she comes, bang, she drops into large valgus. And you can imagine that there are a lot of issues with this, not the least of which she's losing a lot of power, but she's also got some real issues in terms of how she might be loading the different structures. So there are a number of knock-on effects from this. So as a result of this, women also have a greater active internal hip rotation than men. And so we've got this combination of increased hip adduction, increased hip internal rotation, and genu valgum, and this may explain why we see what is often quoted the larger Q angle in female athletes. Now I know the Q angle is extremely controversial, and personally I don't ever measure the Q angle because the literature doesn't give me any reliable scaling for what is normal and abnormal, but it is still worth observing and trying in your mind to figure out what you might think is outside a normal level. But this combo may well be one of the reasons that we see this change between men and women. In fact, way back in 2001, Mizuno and Co., not the shoe manufacturer but the researcher, they established that an increased Q angle was associated with an increase in lateral patellar contact forces. So in other words, we were seeing this change in the way the kneecap tracked across the joint as a result of these biomechanical variables. And this may be one of the reasons that we see a greater incidence of patellofemoral problems in female athletes, and especially in late adolescence. So we particularly see it in female athletes around about 15 years of age. Very, very common problem. All right, what else have we got here? Some other things. Women exhibit greater peak hip adduction, and we can do a really dodgy little video here. You can see how simple this is, but it's very easy to demonstrate this, and it is a fairly uniform thing in female athletes. When you've got a greater hip adduction angle and greater velocity, hip adduction velocity, this places a greater eccentric load on the hip abductors for females compared to males. And so once again, you can imagine that this is a part of why we might start to see some issues higher up the kinetic chain, which also is quite common in female athletes. Specifically, we know that female athletes are about 3 times as likely to develop butt pain, so gluteal pain, and this is probably one of the main reasons that we see this as just a simple overuse mechanism. So we've talked about some of the structural differences. Let's now have a bit of a chat about some of the gait differences, because the forces generated by women runners are also quite different to men, and this is quite interesting for me as somebody who's had a long involvement in the footwear industry, that basically one of the issues with women's shoes, especially if they are downsized men's shoes, is that women cannot take advantage of the material properties of the shoes as well as men can. So I'll give you a simple example. If you've got man X in shoe Y, which is designed for a male runner, he's able to compress the midsole material. So let's say it's a particular EVA material. He's able to compress that material, and he's able to take advantage of the rebound of that material once it unloads. Now, one of the issues with female runners is because they're across the board lighter than men runners, if you use the same EVA, they cannot compress it at the same level, so they can't actually get the same advantage out of the material in terms of rebound. So the spring back for females is just not there. So we've got to think about those issues when we talk about shoe design. The other thing that women exhibit is they exhibit greater vertical ground reaction forces and also free vertical moments compared to men. And of course, we're very interested in moments. I'm not quite so interested in vertical ground reaction forces, but when you start talking about changes in moments, well, then you are actually generating the scenario for injury. Movement patterns. What is it that we're seeing? Do the structural differences predispose to movement pattern differences? Well, I think the answer is probably yes. We see less peak knee flexion in women and also less knee flexion excursion compared to men. So there's an actual, we're not talking about gait now, we're actually talking about the excursion of the specific joint. We also see that there are some changes in terms of the running cycle. So toe off is about the same for men and women, but all the previous investigations have found that women have a shorter stride stance time than men. So that is also a pretty significant finding. There's no consistent data for the swing phase between men and women, so we can't make any meaningful comment about that at this time. The other thing that I alluded to a little bit earlier on is that females run with a very significantly increased anterior pelvic tilt compared to men over the running cycle, and whilst there is no hard data to link this biomechanical variable to injury, we have a very strong index of suspicion that it might be involved. It should be pointed out that it's very hard to measure, so it's quite susceptible to error, but there's been more than a couple of authors who've suggested that if you increase the anterior pelvic tilt during running, it's related to injury. And if you think about that, that makes perfect sense, because you think about how the muscles insert into the pelvic girdle, and we see that fractures the neck of femur and pelvis are substantially more common in female runners. And if we believe that there is a role of repetitive tensile stress to bone in stress fracture, then if you've got an increased anterior pelvic tilt, that would make perfect sense that that may be at least one of the factors that might contribute to this. Hormonal factors are also incredibly important, and I'm going to talk about that towards the end of this presentation. But just be aware that that pelvic tilt is really quite important in terms of some of these injuries that are occurring around the neck of femur, and also especially the inferior pubic ramus. Okay, one of the other things physiologically, I mean, we may as well round this off and be complete here. So physiologically, we also know that women have consistently lower lung diffusing capacity, smaller lung volumes, and also lower maximal expiratory flow rates when you correct this for age and height compared to men. And this is probably the major reason, and I don't want to sound sexist here, but this is probably the major reason that we're never going to see women be able to win a race, an elite woman win a race with an elite man, simply because the physiology is different. And also women are more susceptible to exercise-induced arterial hyperoxemia to men, but we also need to factor in the effect of hormonal cycling. So what this slide tells us is that there are major physiological differences. So there are reasons in terms of the physiology why it's probably not a level playing field at some degree, especially in terms of running. Okay, let's get on to some of the other factors here. So we've gone through the structural differences, we've gone through gait differences, we've gone through positional differences, and we've gone through a very minor physiology. But let's talk about some of the other things. Now, this is the big bogey, and this has been an interest, some of you know this has been a strong interest of mine for many years. That one of the things we know about women is, depending on what you read, that they're about 8 times as likely to suffer a non-contact anterior cruciate ligament injury to men. Now, by non-contact, we mean, don't think about football or something where somebody's, or snow skiing, where you've got a valgus moment and maybe a inflection, maybe a lateral load onto that, which should bust the ACL. We're talking about somebody, think about maybe a netballer who's just running down the court and they fall over and they've ruptured their ACL. So we call this a non-hit or non-contact ACL injury. And it's very, very common in women and far more common than men. And we're trying to understand why. One of the things we do know about women is that there are altered neuromuscular control strategies, and I'll talk about that in a moment. This is very, very important. You can imagine that one of the issues with the knee is that it's a relatively simple joint, and it has, for such a large joint that is such a heavy load-bearing joint, it has very poor or very weak constraining devices. So it only has a couple of ligaments, has the lateral and collateral, medial and lateral collateral ligaments that hold it together, and it's got the ACL and the PCL. But other than that, it is entirely reliant on muscles to stabilize that particular joint. So you can imagine that if you change the neuromuscular control strategies, in other words, if you somehow alter the way the muscles are firing, and if they're not firing at the correct time, or if they're faulty, well then that has a fairly large effect on the way the knee will function, and it does, we think, have quite a role in ACL injury. There are a few other things that are involved here. Women have a smaller cross-sectional area of their ACL, so the ligament size is quite important. The intercondylar notch anatomy is different for women compared to men. And the very important thing, and something I'm going to round this topic off for in the next 15 or so minutes, is the hormonal influences on tendon. Now, the reason I want to talk about this is some of you will have heard me talking about this in the past, but this is something that is going to influence you in everyday clinical practice. So if you don't understand how this all works in female athletes, well then you're probably not going to always get to the bottom of the injury mystery. So I think it's incredibly important that you do understand exactly what goes on here. The other thing that can happen is that the ACL can impinge against the intercondylar notch, And if you've got an ACL that's lodged in a very narrow or A-shaped notch, you can actually get some shearing of the tendon. So it's kind of like a chunk of rope that's shearing against a cliff edge, and it can actually have some influence in ACL rupture. Alright, so specific to ACL injury, what we see is decreased knee flexion angle and increased anterior shear force applied by the quads on the tibia. So obviously the function of the anterior cruciate ligament is to stop the tibia moving forward on the femur. That's its role. So if you've got an increased anterior shear force, well then you're increasing the load on the ACL, and that's not a good thing. Patellar tendon shift angle also increases as the knee flexion angle decreases, so we know there's decreased knee flexion angle. So again, this is all part of the jigsaw puzzle here. And if we look at the equation here, valgus is also very important. So for every 5 degrees of increased valgus, you increase the load on the ACL by about 6 times. So you can imagine this is also a very, very important factor in terms of ACL injury. Increased quadriceps muscle action is also seen as being quite important, and decreased hamstring muscle activation is very important. If you're all still with me and all still thinking about that, obviously the hamstrings are very important stabilizers of the tibia, and with the way they insert, you think about how they insert, they're very important to stop the tibia shifting forward on the femur. So if you've got decreased hamstring muscle activation, then you've got a real issue around the knee. So that's very, very important. It's one of the reasons you guys should always assess hamstring function across the board probably, but certainly if you're ever assessing a knee, you need to be understanding not only how they're recruiting, but when they're recruiting, and if it's working properly. So quite important. Okay, let's talk about hormones now. And as I said, this is not specific to the knee. This is something that I think is very important for you to consider in your injury assessment, but it is very important in relation to ACL injury. So we're talking about things like estrogen, which is a soft tissue relaxant. Estrogen is very important in the childbirth process. If you don't have decent circulating estrogen, you're not going to be able to relax the necessary ligaments that allow a child to be born, and it's going to make the process all that more complicated. So you want to be having plenty of estrogen floating around at that time. So it's a soft tissue relaxant, and it has an effect on the connective tissues, as you'll see in a moment, a very strong effect, and it's across the board. The other thing that is important here is that the receptors for estrogen are present on human ACL, and what happens is they reduce the collagen synthesis and change the fibroblast proliferation. So there's a very fundamental physiological response to these estrogen receptors on the ACL. So the bottom line of this is that estrogen can actually diminish the tensile strength of the ACL. Now, I became very involved in some research in this area a few years ago. We were very interested to have a think about this, and I'm going to present this to you in a few moments. But it's very interesting the way this came about, that the Australian hockey team, Olympic hockey team, the Hockeyroos at that time, were by far the most successful team in the world. They won back-to-back Olympic gold medals. They were the back-to-back world champions, and they had a very, very low rate of ACL injury in relation, or in fact injury across the board, in relation to other teams in the world. And it was very intriguing because their coach at the time was a fellow called Rick Charlesworth, who was a medical doctor. And I don't know whether it's ever been admitted, but the smart money was that Rick Charlesworth required all of his girls to actually be on the oral contraceptive pill, which of course reduces circulating estrogen, which may have a very large role in terms of injury prevention. So it's never been established for sure, but there's been a lot of talk about this, and this is one of the things that really piqued our interest in terms of trying to figure all this out. So the other very important thing about estrogen is that it decreases fine motor skills. So this is the old chestnut where men always say, well, women can't jump and women can't catch. Well, in fact, that's not true at all. Women can jump very well and they can catch very well, but at certain times during the menstrual cycle, if they've got high circulating estrogen, their fine motor skills might decrease, and they may have some issues in terms of catching and fumbling. And many women would identify with this. They drop cups of tea and they do all sorts of things. And ladies, that's just because you've got higher than usual circulating estrogen and your fine motor skills have dropped off a little bit. Now this is also, you can imagine, very important because once again it interferes with the musculature around the knee, and so if that musculature is not functioning properly, well then you can have some change in the neuromuscular control around the knee, so it's very important. So we can have this normal neuromuscular protective mechanism is diminished, and that is a very, very important thing to consider. Now, I'm assuming that most of the people listening to this are podiatrists, but you might also like to think about this in terms of ankle injury. You might like to think about this in terms of plantar fascial injury. It has, in terms of first MPJ injury, it has ongoing influence across the board. And what, if you dig deep enough, what many women will tell you is they'll tell you that at certain times during the menstrual cycle, their athletic footwear is less comfortable than it is at other times. And I'll let you ponder that, why that might be for a moment, because I'm going to give you the answer in just a few ticks, but it's very interesting. All right, so we did some research, and we did that research over about 5 years, and we published it. Some of you may have read a few of these papers. We published our last paper in 2012. But we were very interested in some of the things that we saw as being problems for women athletes. So we were looking at a number of physical tests, and we went through all this normal sort of routine research stuff. It was, in the end, it became very sophisticated research, but pretty standard sort of stuff here. We were very interested in foot pressure and tibial shock. Now, why would we be interested in foot pressure? Well, the reason we were interested in foot pressure is that we had a sneaking suspicion that there was an actual lowering of the arch under the influence of estrogen, because it made the connective tissue made it looser. It made it less compliant. So we were quite interested to see whether there was a change in foot pressure and also in tibial shock over a 30-day menstrual cycle. So we did a PEDAR analysis of all of this, in which we looked at the dominant limb for 30 seconds, and we did a 6-minute treadmill run. And we measured PEDAR data over 2 consecutive menstrual cycles twice a month, once at the start of the month and once in the middle of the month. And we measured tibial shock with an accelerometer, which is the standard way of doing this. We also did a fast Fourier transformation and FFT analysis of tibial shock, and I'll just tell you about that in a little bit. We looked at lower limb musculotendinous stiffness and jump height. We just did a standard 2-odd hertz hopping test on the dominant limb with and without shoes, and on the non-dominant limb without shoes only. So we were interested in this. Again, at the start of the menstrual cycle and in the middle of the menstrual cycle, we were interested in this because we knew about the change in neuromuscular effect with estrogen. We also had a look at, we can get this to advance, here we go, we also had a look at foot length and arch height. In fact, we devised a new measurement technique, which I won't bore you with now, but it is more reliable than the prior method, and it assessed the arch height at half foot length. And the other thing that we had a look at that we felt was quite important was foot musculotendinous stiffness, measuring the windlass mechanism. This is a device developed by Craig Payne. You can see Ross Clark, who at that point was with the Uni of Melbourne. He's now at Australian Catholic University. You can see him getting down, getting dirty there in his lab coat, doing this particular test with Craig's little machine, which gives us very reliable and repeatable subject positioning at 0, 10, 20 and 30 degrees of extension of the big toe, dorsiflexion of the big toe. Okay, so what did we find there? Well, we actually found pretty much what we expected, and that was that there was some change in the PEDAR data and tibial acceleration, that we did see some real flattening over the course of the menstrual cycle, and that this was most pronounced about the middle of the cycle, which is exactly what we expected, and I'll explain why that isn't to you in just a moment. We also saw some changes in tibial acceleration, and we also saw a change in the first MPJ range of motion. So these are all very relevant things for us working in the field of podiatric biomechanics, but the most important thing we measured was to have a look at the Achilles tendon stiffness. So we were very interested to try to figure out whether there was an actual change in the stretchiness or the compliance of the Achilles tendon over a 30-day menstrual cycle. Now, the testing was pretty simple. We put them in an isometric machine. We gave them a 5-second ramp, so a 2-second ramp up and then a 3-second maximal voluntary contraction. and we built a special device that allowed us to do dynamic ultrasound scanning of the Achilles upon neurosis, and we were able to physically measure the change in compliance in that tendon, which we then corrected for joint angle rotation. Now I'm going to give you a little bit more detail about this because I hope you find this interesting. It was a very sophisticated study, as you'll see. It's been published many times over the years, but you can see here's the apparatus. This is the rate of force development with the explosive contraction of the tibia, of the triceps surae, and you can see that we've got this person mounted in the isometric machine, and then we can look at the linear region of the force curve examined. All right, to give you the hardcore details of this now, and I'm going to finish off now, and there might be a few questions, I'm not sure, we'll go back to that in a moment. But to give you a bit of an idea of exactly what went on here, if I can get this slide to advance, which is being slow, but it'll get there in the end. Here we go. Actually, I don't want to go through this because it's a bit of a drag, so let's just move on to the next slide. Okay, so this is the first paper we published. Lead author was Adam Bryant, and in the end we published 6 papers, all different, looking at different things. But this paper was entitled Estrogen Alters the Mechanical Behavior of the Human Achilles Tendon in Vivo, and we published this in the Journal of Physiology, which is an American journal, which is why we spelled estrogen incorrectly as far as I'm concerned, but we had to. So what we know about estrogen, and this is so important in the context of this discussion, is that it decreases tendon collagen density by decreasing fibroblast activity. Now, for those of you that aren't students of histoanatomy or physiology, collagen is the single most important thing in our bodies. It's the building block for every major structure in our body, including tendon, ligament, bone, muscle, fascia. So it's very, very important. So anything that has an impact on collagen density and fibroblast activity, so fibroblasts being the specialized cells that are responsible for depositing collagen, anything that affects that is very important. So we felt that the literature, there was a gap in the literature in terms of telling us how estrogen actually did affect tendon compliance, whether it would actually make tendon more stretchy, which is what we felt it probably did do. Our theory was that as you had higher circulating estrogen, that you would get decreased collagen fractional synthesis rate, the FSR, which means that you would have higher musculotendinous compliance, so more stretch in the female tendon compared to males, and it would result in a smaller tendon cross-sectional area. So if you can see this little graphic here, that this is basically what would happen, that we would get increased springiness. Now you can imagine for the Achilles tendon this is quite a big deal, because it means that there's a greater excursion of the tendon, and that may well be a bit of an issue, as we'll see. Now this we thought would have some real implications for eumenoric women, in other words women who didn't get a period, or oligomenoric women who have a variable period, or for women with constant or attenuated estrogen levels, in other words those who are on the monophasic oral contraceptive pill, henceforth known as the pill. We know that what happens there is that unlike this normal menstrual cycle, you can see the blue line here is women who are on the pill. They get a massive downregulation of circulating estrogen, and it's very linear in comparison to the purple line, where you can see there's a peak at about day 14 and a second peak at about day 19, and then it rapidly falls off. But these peaks are what we think are very important in terms of some injury implications. So we were interested in this question mark about how this low estrogen affected tendon compliance in vivo, and we were then wanting to think about how we might leverage this prophylactic potential of the pill on musculoskeletal injury. Okay, so there are 2 reasons why we looked at the triceps surae complex. One, it's relatively important muscle group, so it's very important for both the absorption of applied load and then returning it, so it has an absorptive and propulsive role during stretch shortening cycle activities. And the other thing is it's actually very easy to measure the movement of the tendon or the compliance of the tendon using ultrasonography, and there's, as you can see from this, there's quite a bit of literature in this area. So this is a little real-time video here that you can see how you can measure the change there of the actual fascicles. Okay, so the purpose of our study was to look at the effect of plasma estrogen levels on the strain behaviour of the Achilles tendon in vivo. So we wanted to know how this acted on this and changed its spring behaviour. As I said, it was quite a sophisticated study. So we took two groups of women, 20 females in each group. We looked at one group who'd been using the pill for more than 12 months, and we used a matched group of women who were not using the pill, and you can see that they were matched for both age, height and mass. They were all runners, so they were running more than 3 times a week and more than 20 k's a week, and they had the usual exclusion criteria in terms of previous injury and illness. So we tested them twice a month, and we followed them for 2 complete cycles, and we looked at the highest, when we would see the highest level of circulating estrogen. So this is in the non-pill users. So we looked at this point and this point. So at about day 14 we've got the highest circulating estrogen, and at the start of the menstrual cycle, day 1, we've got the lowest circulating estrogens, lowest circulating estrogen. We got them to plug into an online program called Fertility Friend. Fertility Friend is a program that helps women to predict when they're most fertile and assist them to get pregnant. And we also looked at urinary test kits in the second cycle to also try to tell us when there was a high concentration of estrogen. More importantly, we tested the pill users at day 1 and day 14 to match it with the non-pill users. And we then really refined this by taking 10 mils of venous blood from the brachial vein, the subbrachial vein. We subjected it to an ELISA analysis, which allowed us to very accurately titrate the estrogen levels, so we knew exactly what was going on here. So we then made the special ultrasound jig, which allowed us to measure the actual change in the isometric force development over time for the Achilles tendon, and we could then apply this little equation down here to allow us to calculate the Achilles tendon strain. All right, stats I'm not going to bore you with because everybody hates statistics, but let's get on to the results here. So first of all, the question is, well, does the pill work? That's a pretty important question. And this is the plasma estrogen levels for non-pill and pill users. You can see the purple is women who are not using the pill, and green is those that do use the pill. And it's pretty obvious that there is a major downregulation of the estrogen levels in the pill users, which is what we would expect to see. When you look at the main effect of this, you can get a real idea of this. About a 70% reduction, a highly statistical reduction in the amount of circulating estrogen for those women that were using the pill. Looking at the force, we were interested to see whether the plantar flexion force was affected for the 2 groups, and again, purple is non-pill and green is the pill. And you can see that on both occasions there was an increase in plantar flexion force for those women who were on the pill, but in this particular measurement not statistically significant. And also looking at the Achilles tendon strain for the 2 groups, and you can see that it's pretty clear, again not in this particular graph, that there is a reduction in the strain development for women who were on the pill. So a fairly major finding there. When we look at the main effect of this, you can see a fairly major statistical difference here, that those women who are using the pill develop less Achilles strain than women who are not on the pill. So what does it all mean? It simply means that if you're not on the pill, then you have greater estrogen fluctuation over the gait cycle, over the menstrual cycle. As soon as you administer the oral contraceptive pill, you get consistent estrogen down regulation to the degree of about 70%, and you can see this. This is all within the ranges that have been previously reported, but we did find that there were not any significant influences on muscle strength. Be clear that we're talking about strength here, we're not talking about timing, we're only talking about strength, but there was no change in that. In contrast, what we did see is we saw that women who used the monophasic oral contraceptive pill had a fairly major altered spring-like behaviour of the Achilles tendon. So the Achilles tendon of the pill users the strain was decreased for the equivalent muscle force compared to the women who are not on the pill. So in other words, if you're a non-pill user, you get greater stretchiness of the Achilles tendon, and this really has some pretty significant implications, as you're about to see. So in summary, what we saw is the Achilles tendon strain in women who were on the oral contraceptive pill was significantly decreased, and we think this was probably through collagen synthesis. I won't go into this, but physiology is quite interesting if you're into that sort of thing. But if you decrease the estrogen, then you increase the fibroblast activity, and that is going to alter the gene expression for type 1 collagen. So you're going to get more collagen laid down, basically. So in terms of long-term pill users, we think they get exercise-induced collagen production, so they get better, more dense collagen, and this is quite interesting, especially in terms of things like ACL grafts. So if you're taking a graft from a woman who is on the pill rather than a woman who is not on the pill, there is some very distinct possibility that you're going to have a stronger graft. So that's actually being looked into as we speak. So there are numerous implications in relation to all this. First of all, the capability or the capacity to harness elastic strand energy is much different for women who are not on the pill than women who are on the pill. Women who are on the pill are able to harness it much better. There's probably also resistance to long-term structural damage for women who are on the pill rather than not on the pill, and there's a lower rate of joint injury. So if we took the ethical considerations out of this, if we took any moral considerations out of this, we would probably be able to say with a fair degree of confidence that for women playing a lot of sport, especially elite athletes, it probably makes some sense to put them on the pill. I know that's pretty controversial, but based on this research and other research from around the world that's ongoing, that seems to be the equation. As I mentioned, very interesting implications in terms of how and from whom you should harvest an ACL tendon graft. So the conclusion here is that if you take the oral contraceptive pill, your estrogen levels are decreased. This is going to decrease your Achilles tendon strain, and ultimately this is going to increase your collagen density, and that is seen as being necessarily something that has very good practical and clinical implications. What are these implications? Well, I'm a footwear guy, so I always go back to this, so look at this from that perspective, but it also has implications for things like orthotic therapy. From a footwear design perspective, you need to recognize that there are mechanical and hormonal gender differences. So we started off this presentation saying, look, there are tons of differences between men and women. There are structural differences, there are gait differences, there are physiological differences, there are joint differences. So we need to understand those pretty well, because all of these are going to affect the behavior of tendon and ligament, and they're all going to be influenced by estrogen, and they all are going to have, at some level, an effect on the potential for injury. We can design women's footwear to improve performance and safety. We can think about gender-specific orthotic therapy, perhaps. You need to be thinking in your own mind about how all of those structural changes might influence what you do. So I can give you an example from a footwear perspective. The touchdown angle for women versus men runners is different. The adduction angle is different. The external rotation is different. The ability to compress and utilize EVA materials in the midsole is different. Women have a relatively narrower forefoot to rear foot relationship, so their heel is narrower than their forefoot compared to men, so the fit is different. Women tend to have issues with heel fit. So I can list 5 things just off the top of my head that have major design implications for footwear. So shrinking and pinking it is not the way to go, and I think we need to get serious about how we might design things. You might also like to think about the implications for this in terms of orthotic therapy. Are you doing exactly the same thing for your female athletes as you are for your men athletes? If you are, then I don't think you're doing it properly, and you might need to just reconsider that. Okay, so that's the end of the show, guys. I have lost my little thing there. I hope I've still got a few with me. Yeah, I've got a few here still. I'm not sure whether we've got any questions or not. If not, it doesn't look like we've got any questions here. So we've been going now for about 50 minutes, a bit more, so I think that's more than enough, and we'll probably end it there. I just want to say thank you to you all for attending the webinar. There's a bit of a mixed bag of information there. Some of it's pretty research driven, some of it is just stating the differences, but the important thing to remember is that the differences do exist, and the differences are very important in sport. We've talked primarily about running, but you might be looking after netballers, or you might be looking after basketballers, you might be looking after soccer players, and the rules apply for these sports as well. Okay, so thanks again. Thanks to LBG Medical for putting on this webinar. We'll be doing another one soon. Anybody who has my contact details, you can contact me through www.bartolbiomechanics.com if you've got any topics that you want to discuss. Also be aware that you can join that website if you want. It's a members-only website. It's dirt cheap at 200 Aussie dollars. You get some incredible resources if you want to get on board and have a bit of a look at it. www.bartolbiomechanics.com. So I think I've got one question here. Let me have a look. Say Achilles. Okay, Achilles. I'm saying it. That's the only question I have. So I think I've answered that question, Achilles. And I will leave you all now. I hope you have a great rest of the day, and I'll speak to you again soon. Bye for now.